It's a delight to be here. I'm going to use this microphone so that I can be a bit mobile. I don't like standing behind this podest. Let's see if this will work. My name is Klaus Witte. I'm a cardiologist in Leeds, and the topic of the talk is remote monitoring for GDMT, which is, of course, a charming topic title, but is not reflective, actually, of what our target is, right? We want remote monitoring to reduce hospitalization, remote monitoring to extend life. And if that goes with the use of GDMT and remote monitoring helps us achieve that, then that's a good thing. But our patients don't care about GDMT. They care about being in hospital or not. These are my conflicts of interest. Now, there's no question that heart failure is a huge problem across the world, across Europe, across Asia, across the Americas. Oh, yeah, I'm fine, don't worry. Let's keep going. And it consumes a huge amount of healthcare budget, and it also leads frequently to rehospitalization after discharge, and also, of course, is associated with shortened longevity. This is the same in your country as it is in mine, and as we move into a Western style of living, we have problems with chronic cardiovascular disease increasingly, and you can see the data here from India over the course of the country. I wanted to show some information about rehospitalization. Here's some data that's actually very new. And of those patients hospitalized with heart failure, 17% will be rehospitalized within the year, and 22% will die within the year. That's a huge rate of events. But it's also important to recognize that 60% of people will not be dead or hospitalized in the first year. And of course, that's a challenge. There is little point in remotely monitoring somebody who's not going to be hospitalized and who's going to be just fine. So over the course of the talk, we'll talk a little bit about how we can select people better. The other thing that I often hear from my non-heart failure colleagues is, well, how can you prevent an acute decompensation of heart failure? Well, this slide shows you quite clearly that heart failure is very rarely acute. There's often weeks of deteriorating symptoms before these people come into hospital. And we also know that actually a large number of patients who are admitted with acute decompensated heart failure don't have decompensated heart failure. They have something else that has made their heart failure worse, or that is functioning as a comorbidity. So this whole concept of acute decompensated heart failure needs revising. And we do have time to intervene. What is the holy grail of remote monitoring? It is, of course, that we identify people at risk, we figure out exactly what might be going wrong with them, and we intervene early to avoid their hospitalization and or stop them dying. And this leads to faster diagnosis, faster therapy, reduced days in hospital, perhaps hospitalizations avoided. Also, speeded up discharge, which is really important for patients. And overall, this is associated with improved quality of life and lower costs. But as I've already hinted, who are we going to monitor? What are we going to monitor them with? And for how long? And what intervention are we going to do in order to make our monitoring work? Because as I've suggested, 2/3 of people that have been hospitalized with heart failure aren't going to be rehospitalized and aren't going to die over the subsequent year. Now, when we look at variables predicting rehospitalization, it is a dog's dinner. There is a huge number of potential variables, and pinning these down is incredibly difficult. So I put it to you that demographics pointing out who is going to be rehospitalized simply by epidemiology is almost impossible. On the other hand, if I see my patient in clinic, there are a couple of features that they don't have that reassure me that they're not going to be hospitalized. So there's no ongoing pulmonary congestion, they've got they're not ischemic in origin, and they're on a small dose of diuretic, they're going to be fine. There's no point monitoring him or her. I can see them in a year and they'll be fine. So you could alternatively say, should we identify those people who are going to be fine? That might be easier. So let's talk about the variables and which method We need something that is a strong predictor of hospitalization. We need something that we can intervene upon, and that intervention changes the outcome. Otherwise, there's no point. So here's just some of the variables that I think might be of relevance. Heart rate, maybe some measure of congestion. And over on the right there, we've got some other items that might be relevant, bearing in mind what I said before, that our patients with heart failure have a vast number of comorbidities, all of which can contribute to a destabilization of their syndrome. And I don't like this graph here by Anchor, but it does tell us one thing, is that our patients rarely come with heart failure alone. So how could we monitor? And this is what Gianluigi and the organizing committee really want us to talk about, isn't it? How can we monitor our patients? Well, we can use implantable devices, we can use external devices, we can use direct-to-consumer wearables, we can use internal congestion monitors, vascular congestion monitors. And there are also these suggestions that we could use external congestion monitors. We could strap a band around someone's leg and figure out whether or not it's swelling, or to see if they've got fluid on board. But whatever we choose, it has to be acceptable, it has to be inexpensive, or at least it has to be cost effective, and it has to be remote, but it also has to be proven in your healthcare setting, in my healthcare setting, in Gianluigi's healthcare setting, in the States, each of which are very, very different healthcare settings. So we can predict hospitalization using implantable devices. Here you see very old data from 15 years ago suggesting that there are some variables that matter. The challenge is when you look at this incredibly impressive Kaplan-Meier graph, you have to look at the y-axis. 7%. That for me means that out of those people that fell into the high-risk category, only 7% were actually hospitalized. And this is one of the major problems. One of the major problems with remote monitoring is specificity. I don't want to do a vast amount of activity to a vast amount of people to end up not reducing hospitalizations, because then I spend costs and I have patient activity and personnel activity for no overall benefit. You'll see the classic example of congestion measured by a device here, leading to an enormous amount of activity but no overall outcomes. So the remote monitoring must reveal a condition for which there is an intervention that alters outcomes, and we cannot assume that things that predict hospitalization will necessarily predict an intervention that we can do something about. So where does that leave us? All is not necessarily lost regarding device monitoring. Here you'll see 3 modestly sized studies done in Germany, which is a very unusual healthcare setting, with daily downloads of all sorts of measures and a coordinated response that led to a reduction in overall mortality and cardiovascular hospitalization and hospitalization for worsening heart failure. But Germany is not Sweden. Germany is not the UK, and Germany is not South Asia. So I'm not sure that these data will work here. And I'll talk a little bit about why Germany is different later on. On the converse, here's a study from the UK, just to prove my point. Exactly the same level of activity, no difference in outcomes. Because these patients with devices, they're already in a program. They've had their devices 2 years, so they're already the survivors. So additional therapy, when they're on really good therapy, maybe doesn't help necessarily. Nevertheless, the ESC and the Americans suggest that we should remotely follow patients with devices, which is fine. But what about patients without devices? What about patients who have been in hospital recently? What should we do with them? How about we consider some form of non-invasive telemonitoring device? Here you see TIM-HF2, which is a study of this device here. A huge amount of activity, 765 people with an admission in the last 12 months. They're not allowed to be depressed. because the forerunner of this showed that the depressed patients didn't benefit. And what was done? Lots and lots of daily measures, including heart rate, oxygen saturations, blood pressure, and lots of patient education. And that led to a structured intervention based on a change in a risk marker. And you'll see here that in these 700 patients over 12 months, there were over 1 million interventions. Okay, that's an unbelievable amount of activity done by 4 physicians, 5 nurses working full-time, 765 people. Also on call, full-time overnight service. Now, of course, if you do this much to patients, there is the potential that you can reduce your hospitalization rate. Basically, you're changing their diuretics every day. So fewer days in hospital, and there seems little heterogeneity, so it does seem to work. But this is unaffordable in almost every healthcare environment in the world, including the States, I'll tell you. So how about congestion? Well, we know congestion leads to hospitalization. It's very common. We can measure it, and we think that giving people diuretics will ease it, and therefore reduce the chances of needing to come into hospital. So it is common in hospitalized patients, and when they come into hospital, you give them diuretics, the congestion goes, and they feel better. Can we measure it? Well, yes, we probably can. We have the data from Champion showing in 550 people that you can measure congestion in a pulmonary artery pressure monitoring way. And if you do this, you can intervene by using diuretics, vasodilators, which in an American setting means hydralazine and nitrates, and in a more European setting means diuretics, higher dose of ARB, maybe some nitrates. And that, again, leads to an incredible amount of activity, and interestingly enough, doesn't lead to a persistent change in diuretic dose. You'll see here that although they had a vast number of activity, the diuretic dose went up and down and up and down and up and down, but at the end was the same. And over 15 months, there was a reduction in PA pressure, mean PA pressure, and a reduction in hospitalizations. Guide HF did much the same thing, just more American population, more American patients, a larger sample size, attempting to gain information on mortality benefit, and again, a huge amount of activity over 12 months, no difference overall in the primary outcome. So do not think that pulmonary artery pressure monitoring necessarily in your setting will be the holy grail of avoiding hospitalizations in these patients. You'll increase activity, but it won't necessarily reduce your hospitalization rate. Now, there was a subgroup analysis done around COVID, and you'd have thought people would benefit more during COVID, but they didn't. They benefited less during COVID. Why? Probably because nobody came to hospital during COVID. So COVID led to fewer hospitalizations, and that then led to the fact that actually people who really didn't need to be in hospital didn't come into hospital, negating the benefit of the PA pressure monitoring. There was some heterogeneity in people who are perhaps less well managed or people with more severe heart failure. It seems to work better. The final study of this device was done in Europe. This was about hospitalization, and over 12 months, an enormous amount of activity, a reduction in BNP and PA pressures, and an improvement in quality of life. Now, this I can go for if my patient doesn't get hospitalized either way. If my patient's mortality doesn't change, but their quality of life is better with this device, then it's worth considering. So, KCCQ went better, there was a hospitalization reduction and a lower PA pressure. I'm not going to talk about this other device. This is a further device that is similar outcomes, similar effects. You just need to know there's a second device out there that can do it. There is a third device that goes into the inferior vena cava. It tracks PA pressures, it tracks congestion, it tracks BNP, and in 50 people, if you follow what it shows you, you can reduce hospitalization. So this is at an early stage, this whole process, who we monitor, which of the devices we monitor with. It's an early stage and needs to be tested in different healthcare settings. Nevertheless, there is certainly a lot of promise with remote monitoring for congestion. Let's briefly talk about some of the other things we can think about. What about this concept of non-heart failure hospitalization in a heart failure patient? Temperature, patient activity might give us a good idea that they're at higher risk. What about optimizing their diuretics using sodium? We try to reduce diuretics, but that comes at a risk, doesn't it? We know loop diuretics are a problem. We know they can cause renal dysfunction, but it does come at a risk that we precipitate congestion and hospitalization. If we measure the sodium output in the urine and it remains high, the sodium in the urine, and it's drifting, then we know that the patient is at greater risk of subsequent congestion and subsequent hospitalization. So this is a way in which we could tailor our diuretic dose for our patient's sodium output, safely reducing diuretics in people who might be at risk of renal dysfunction. So I'm going to come on to something that might be off-label a little bit, temperature and patient activity. Again, multiple comorbidities. You'll see here patients are dying of non-cardiovascular death far more than they used to. And one of the things that we're increasingly recognizing is that inflammation and infection are hugely important in determining hospitalization and outcomes in these patients. CRP, high sensitive CRP, a great marker of risk in patients with heart failure. Why? Because we have immunocompromise, we have a poor response to vaccines, we have chronic inflammation, and we have a lower response to infection and more immobility, such that this can precipitate an hospitalization and congestion. Because we know that pneumonia rates are much higher in patients immediately post-discharge than they would otherwise be. So infection is a huge issue. Be wary of that as you go forward. How do we measure it? Well, how about a loop recorder that can measure in temperature? You see the temperature go up, you give the antibiotics, the temperature comes down. This is certainly on the horizon, ladies and gentlemen. What about another way of measuring response to optimal medical therapy post-discharge? We know that if the patient's quality of life and activity levels remain low post-discharge, they're at very high risk, and you should see them in clinic. Otherwise, they will end up in hospital. Finally, I'm going to make one point. If we get our patients on optimal medical therapy, optimal doses, not just the 4 pillars, but the optimal doses of the 4 pillars, we will largely negate the need for remote monitoring in a large proportion of our patients. Remote monitoring is not an excuse to mismanage or submanage patients. So don't forget that. We don't do it often enough. Even in the States and in the Netherlands, they don't do it often enough. So, data on efficacy of remote monitoring are accumulating. We still have a lot of questions to ask. We need to get the drugs right first and foremost. There is still no randomized controlled trial of a pathway of care. There are lots of trials of this device and that device and this alternative way. There's no trial of a pathway of care incorporating remote monitoring in subgroups within that pathway of care. We seem to know about some of the benefits of it, but there's lots of things that we still don't know. Thank you very much.